At the very beginning, it was deep gratitude and genuine appreciation that I extend my heartfelt thanks to my esteemed brother and dear friend, Dr. Fawaz al-Monjid, for his kind invitation and for affording me the honor of participating in this distinguished seminar. Uh, Actually, occupational COPD is an enormous concern for internal medicine, for respiratory diseases consultants and specialists, and in occupational medicine practice. It's a topic of enormous significance. It's no longer just a concern of lifestyle or genetics. Occupational exposure actually play a significant and often underestimated role in its development and progression. Uh, Here I declare that I have no conflicts of interest related to this presentation. I have no financial or professional affiliations with any pharmaceutical companies, medical device manufacturers, or any other organizations that could influence the content of this session. This presentation is based on the latest scientific evidence and clinical guidelines. Here's our agenda. To guide our discussion today, we will start with a brief overview of COPD, to be followed by its risk factors and pathogenesis, and then we will cover the types and the clinical presentation, move on to investigations, and conclude with management approaches and key references. So let's begin. And to catch your eyes, we will start with an overview of chronic obstructive pulmonary disease. Considering the conceptual aspects of chronic obstructive pulmonary disease, as all we know, it's a long-term, progressively worsening lung condition. Usually it's marked by persistent inflow obstruction that cannot be fully reversed. It's usually irreversible. It includes chronic bronchitis in addition to emphysema, usually leading to airway inflammation and structural lung damage that may be ending with fibrosis. COPD is a major global health concern, making as the third leading cause of death worldwide. Its prevalence usually varies across, as we know, across regions from some region to another one due to differences in risk factors, for example, such as tobacco use, environmental pollution, and workplace exposure. I mean here the occupational exposure. Pulmonary disease affect over a billion people globally, underscoring their immense burden on global health system. Among them, COPD alone can account for nearly 392 million cases, highlighting its significant contribution to chronic respiratory morbidity, and even more the urgent need for early detection, prevention, and actually management strategies worldwide. Moving now to discuss the situation of COPD among the GCC countries, and by having a look at that graph, we can find, or it's quite clear that there is a noticeable upward trend in the prevalence of COPD among individuals aged 40 or more years old across most of the GCC countries, reflecting a consistent and region-wide health concern. We can find that the highest prevalence rates are reported in Kuwait and Saudi Arabia, definitely suggesting a more significant disease burden in these nations. And by consequence, this pattern underscores the urgent need for enhanced preventive strategies, early detection, and improved respiratory health initiatives across the Gulf. But as a positive note, and fortunately, Qatar consistently reports the lowest COPD prevalence in the region, likely maybe due to, or likely reflecting the impact of its robust public health measures, a cleaner environment, and maybe due to effective tobacco control policies. As we mentioned before, Qatar reports the lowest prevalence of COPD among GCC countries, which can be attributed to a combination of proactive public health initiatives in addition to environmental policies. Contributing factors, for example, may include lower smoking rates, comprehensive tobacco control measures, such as, for example, high taxation, advertising restrictions, and strict anti-smoking laws, rigorous air quality regulations to ensure better air quality. Furthermore, enhanced occupational safety standards and the widespread use of clean energy sources have minimized the indoor air pollution. The fifth contributing factor, unlike some rural areas in the other GCC nations that still rely on biomass fuels, Qatar's shift toward cleaner energy that has played a key role in promoting better respiratory health across the population. Now we can move one step forward to discuss the risk factors of COPD. Is it important? Yes, it is. Because recognizing the risk factors for COPD is essential for its prevention, for early diagnosis, for effective management. So by identifying these triggers, the healthcare providers and policymakers actually can implement targeted interventions that reduce the disease burden. So it's very important to discuss the risk factors. Unfortunately, smoking still be the leading cause of COPD. So it's the first risk factor of enormous and high importance. And to know how effective is or how bad is the effect of smoking as a risk factor, we should discuss strengths of association and dose response relationship. The first part is strength of association. We can detect that up to 90% of COPD cases are linked to smoking. Smokers are almost 12 to 13 times more likely to die from COPD than non-smokers. Up to 25% of chronic smokers develop clinically serious COPD. Stopping smoking slows the disease progression and improves symptoms, even in a very advanced case. But on the contrary, however, some lung damage is irreversible, highlighting the importance of early cessation of smoking. Moving to dose response relationship, we can find that high nicotine types, which are more harmful, the number of cigarettes smoked per day, the number of puffs taken per cigarettes, keeping the cigarette in between puffs, age of commencement or starting of smoking. Filter tipped cigarettes are less harmful. Shisha has higher risk of developing the disease. Pipe and cigarette smokers have less prevalence of the disease. Exposure to side smoke increases the risk among the non-smokers who sit before the smokers. Smoking among parents definitely increases the risk among their children. Collectively, the pathogenesis is usually chronic persistent small airway inflammation with mucus hypersecretion, fibrosis, and airway remodeling. Also, with an imbalance in between protease and antiprotease, this actually produces tissue damage and destruction. There's also oxidative stress and consequently also small cell damage, pulmonary vascular damage, and pulmonary hypertension. Considering the environmental exposure as a very important risk factor for developing COPD, what is so strange and weird, although that we are in the 21st century, there are almost over 2.6 billion people worldwide are still relying on biomass fuel. Biomass fuel combustion used for cooking and heating in poorly ventilated homes certainly found in low socioeconomic areas and poor countries. Uh, this type of fuel produces high levels of particulate matter sorry, and toxic gases, which definitely can lead to a chronic airway inflammation and lung damage. This is the most important part in indoor air pollution. Considering outdoor air pollution, particularly the fine particulate matter, PM 2.5, nitrogen oxide, and ozone, has been strongly also linked to reduced lung function, exacerbation of COPD, with increasing the respiratory morbidity and mortality. The outdoor and indoor air pollution, both together, we can find nearly 99% of the world's population breathes air that exceeds the recommended pollutant levels, with almost 7 million people deaths annually. Continuing with environmental exposures, it was found that the association between COPD and certain occupational exposures is well established and even can be quite significant, more significant, particularly in individuals with long-term exposures or high-level exposures to respiratory irritants in the workplace. It was found that occupational exposure to dust, fumes, chemicals, or any other respiratory hazards account for an estimated 15 to 20% of the COPD cases among the general population, which almost account for 392 million workers and even smokers or non-smokers. Among the never smokers, occupational exposure play an important greater role, accounting for 20 up to 30% of COPD cases, which means that occupational exposure is a very important or a significant risk of paramount importance risk factor for developing COPD. Take care, even for those who have never smoked. The question now is, how strong could the association between COPD and certain occupational exposure be? This graph highlights the gradient of occupational risk of COPD, emphasizing that coal mining, construction, and foundry work have the highest risks due to heavy exposure to dust, fumes, and chemical agents, while mid-range occupations such as textile, agriculture, and welding also demonstrate significant risk, reflecting chronic inhalation of organic and inorganic particulates. Notably, it's worth to mention that even occupations like firefighting and healthcare work, so less industrial, but so increased also COPD risk, likely may be due to smoke, disinfectants, and indoor pollutants. While the relatively low risk, as we see among the office workers, serves as a reference baseline, these findings underline the importance of tailored preventive strategies in the high-risk work environment. Understanding aerodynamic behavior is very important to understand the pathogenesis of environmental exposure as a risk factor in COPD causation. Aerodynamic behavior usually describes how inhaled particles deposit in the lungs based on their size. So we can find that large particles, which are more than 10 micrometers, are mostly filtered in the nose and upper airways, while the fine particles, those who equals or are less than 10 micrometers, usually deposit also in the bronchi, where the PM 2.5 equals or less than 2.5 micrometer usually can reach the small airways and alveoli and drive COPD pathogenesis. Whereas the ultrafine particles, which are less than 0.1 micrometer, can reach the alveoli and may even cross into the bloodstream, contributing to local and systemic inflammation in COPD. The fine and ultrafine particles can bypass the airways and deposit deeper within the small airways, as we saw, small airways and alveoli, where they trigger chronic inflammation, oxidative stress, and structural remodeling. Persistent exposure to those ultrafine or fine particles usually lead or can lead to airway narrowing, goblet cell hyperplasia, alveoli or alveolar wall destruction. That is the hallmark features of COPD. Additionally, the soluble gases like, for example, ozone, nitrogen oxide, can penetrate also the lower respiratory tract, exacerbating epithelial injury and amplifying the inflammatory cascade. These aerodynamic and chemical properties of pollutants are fundamental in driving or in causation COPD and COPD progression in both smokers and non-smokers exposed to pollutant environments. So we can conclude that environmental exposures is a very important risk factor for developing COPD, either in smokers or non-smokers. Uh, Now we want to speak about other contributing factors, and take care here. I'm saying contributing factors, not risk factors, because risk factors are characteristics or exposures or behaviors that increase the likelihood of developing disease. They can be modifiable, like smoking, as we discussed before, occupational exposure, or environmental factors. But contributing factors are broader influences that play a role in the progression or severity of the disease, but may not be directly cause it. So the contributing factor cannot cause the disease, but it can contribute to the severity or deterioration of the disease. They can include social, environmental, or workplace conditions. Very rapidly, the other contributing factors like gene environment interaction. Inherited factors interact with the environmental exposures, making some individuals more susceptible or more prone to the lung damage and disease progression. Also, low birth weight and prematurity leads to underdeveloped lungs and reduced lung functions in adulthood, so it can develop any other disease like many infections later, or COPD or bronchial asthma or whatever. Poor nutrition during growth period may cause lung damage and increase the susceptibility to COPD later in life. Frequent childhood respiratory infection usually cause high probability or contributing factor to develop COPD later in life. Uh, Other contributing factors like microbiomes and gut-lung axis. Microbiomes is a diverse microbial communities, including bacteria, viruses, fungi, or whatever that inhabit the human body. Disruption in such communities, we call it dysbiosis, can worsen the airway inflammation and impair defense mechanisms, accelerating disease progression, increasing the probability of developing any problem in the lung, especially COPD. What is the gut-lung axis? Uh, Gut-lung axis links the gut health to the lung condition, where changes in the gut microbiomes can impact respiratory health and vice versa. Again, so the disruption in such axis may worsen the respiratory issues, reinforcing disease progression. With the autoimmune dysregulation due to exposure to whatever, like smoking, air pollution, or occupational exposure, this is harmful to the lung tissues and cause many health problems, including COPD. Last one is lung senescence. Lung senescence increases the age of lung tissues. This accelerates aging-related lung dysfunction by impairing repair mechanisms, by increasing inflammation. This usually causes oxidative stress. This process weakens the lung elasticity and regeneration, contributing definitely to many diseases. One of them is COPD development and progressive airway damage. Now we are ready to delve and dive directly into types and clinical presentation of COPD. And it's worth noting that chronic bronchitis and emphysema were traditionally considered distinct diseases. Nowadays, they are better understood as phenotypes or clinical presentations. So, chronic bronchitis or emphysema are not separate diseases, but they are phenotypes or clinical presentation within the broader diagnosis of COPD. Uh, okay, so the first phenotypes of COPD, which is the more common, is chronic bronchitis, which is characterized by chronic product, or the definition. Chronic bronchitis is defined as chronic productive cough lasting 3 months or more per year for at least 2 consecutive years, characterized by excessive mucus production with frequent respiratory infections, with dyspnea on exertion, but usually less prominent in early stages and more common at later or at later stages. Uh, Chronic bronchitis phenotype is characterized by cyanosis due to chronic hypoxia. There is also peripheral edema due to cor pulmonale, which is pulmonary hypertension. Consequently, the cor pulmonale is characterized by bloating. And here we have to point out that some physicians describe the chronic bronchitis or the blue bloater as obese person. It's not an obesity. Bloating is nickname of the chronic bronchitis, which means something like inflation. Uh, it's due to salt and water retention, commonly due to pulmonary hypertension or cor pulmonale. That's why the chronic bronchitis phenotype is named or known by blue bloater. Blue due to cyanosis, bloater due to bloating. And there's a lot of physiological explanation of such conditions. To save time, I prefer to keep it later in the discussion if you want to know the details. The second very common phenotype of COPD is emphysema, whereas the patient here is completely different from chronic bronchitis. First thing, he has from the start progressive dyspnea, but initially dyspnea will be on exertion, later it will be at rest. Second, minimal cough with scant or little sputum production, unlike chronic bronchitis. Here is weight loss. There's no inflation or no bloating. There's weight loss and muscle wasting due to increased work of breathing, which consumes a lot of energy. His chest is barrel shaped due to hyperinflation. Uh, he or she breathes with pursed lip. We call it pursed lip breathing to maintain airway pressure and prevent collapse. He's not cyanosed. He's not blue. He has he has pink complexion. Why? Due to compensatory hyperventilation, which maintain oxygenation until later. So this type of or this stereotype has no cyanosis. That's why we call him pink puffer. Apart from the chronic bronchitis and emphysema as the common phenotypes of COPD, we have non-common phenotypes of COPD, like what happened in overlapping between bronchial asthma and COPD. We call it asthma COPD overlap syndrome. Also, association between bronchiectasis and COPD. It's bronchiectasis associated COPD. Uh, Maybe COPD is accompanied with systemic disorders like COPD related sarcopenia, where the chronic inflammation happened in the lung tissues and the inactivity as a consequence lead to loss of skeletal muscle mass, contributing to frailty or weakness with exercise intolerance. Such patients are unable to do any physical effort. Association between COPD and cardiovascular complication. We mentioned it before that COPD increases the risk of heart diseases, including pulmonary hypertension, right heart failure, cor pulmonale, maybe also atrial fibrillation due to chronic hypoxia and systemic inflammation. Usually, the COPD patients are depressed and have a lot of anxiety. So they have cognitive decline and depression. Why? Because of hypoxia and systemic inflammation have been linked to cognitive impairment and higher rates of depression and anxiety in COPD patients. Now we have to reach another very important conclusion that COPD is no longer a purely lung disease rather than a systemic disorder. It's now considered a systemic disorder rather than to be only purely lung disease. Please remember this statement. Considering the differences in between smoking related COPD and occupational one, we can find that the typical onset among COPD-1 can occur earlier, even in non-smokers, was almost linked to long-term smoking history in smoking-related one. Symptoms are usually the same but may fluctuate with work exposure and improve on weekends and vacation. Disease severity, definitely it's linked to the occupational exposure. So may develop with lower exposure, but progresses with continued work exposure. The pathology where it's either emphysema or chronic bronchitis among smoking-related COPD. In occupational one, it's more airway inflammation and small airway diseases with more chronic bronchitis and less emphysema. Spirometry, usually the same, but the DLCO often preserved. DLCO, diffusion of carbon monoxide. Imaging findings in occupational, according to pathology, it's usually that one of chronic bronchitis, so we can find more airway thickening and bronchial wall changes. What we call it BV markings, bronchovascular markings. The progress improves or stabilizes if exposure is removed early. So we can say as a conclusion that occupational COPD manifestations all are depending on the occupational duration and occupational concentration. Management medication in addition to exposure control. Moving one more step forward to discuss the investigations of chronic obstructive pulmonary disease. Cut to the chase, and without any further ado, we can decide that post-bronchodilator spirometry is the corner or keystone in diagnosis of COPD. But why should we use the post-bronchodilator one and not the regular one? The answer is very easy. Using bronchodilator spirometry enables us to differentiate in between the reversible obstruction, like in bronchial asthma, and the irreversible obstruction that occurs in COPD. Second, using the bronchodilators can enable us to assess our treatment plan, and we can assess the prognosis and severity of the disease. Here we use what's known as GOLD. GOLD is a global initiative for chronic obstructive lung disease classification based on two tools. First one is spirometry. Second one is symptom burden. The table of spirometry, this table outlines the GOLD classification for, as we see, for COPD, which categorizes disease severity based on percentage of the predicted FE1, which is a key diagnostic criterion for COPD. Take care here, the key diagnostic criterion for COPD is reduced FEV1 over FVC ratio less than 0.7. And the severity of airflow limitation here is determined by the FEV1 value. So patients with 80% or more are classified as mild, as we see. Those with values between 50 and 80 as moderate, and severe in between 30 and 50%, whereas those below 30% as or diagnosed as very severe COPD. This framework is essential, as we see, for diagnosis COPD and guiding also the treatment strategies, as we said before. With the gold ABCD, the second table on the right side, the CAT, it's a COPD assessment test, whereas the MMRC is a modified medical research council dyspnea scale, are valuable tools also used in evaluating the impact of COPD patient. It's clear that a CAT score of 10 or more indicates a high symptom burden, reflecting significant impact on the patient's quality of life, while the MMRC score of 2 or more signals that patient is experiencing significant breathlessness. Together, these assessments provide a comprehensive view of the patient's respiratory status, enabling indications to tailor treatment strategies more effectively and monitor changes disease severity over time. And we can see here that the exacerbations among the group A and B is 0 to 1 exacerbations, no hospitalization. But it can be classified into low and high according to CAT and MMRC. Also, group C and D, the exacerbation history is equal to or more exacerbations or more than one hospitalization. Also can be categorized into low or high according to CAT and MMRC. To summarize what we discussed in the previous slide, it's quite clear here that we can differentiate in between COPD and bronchial asthma using the post-bronchodilator spirometry, where we can find that the FEV1 over FVC ratio is decreased, which is persistent. A response to bronchodilator is mild or no significant improvement. Forced vital capacity may be reduced, while it's normal in the bronchial asthma. Total lung capacity is increased due to air trapping in COPD. This may occur in bronchial asthma, but very late in severe cases. Residual volume also increased in both conditions, but increased usually during attacks in bronchial asthma. Diffusion capacity of CO, carbon monoxide, is normal or decreased, especially in emphysema. So it's normal in bronchial asthma. There is no diffusion capacity in decrease in bronchial asthma. What's the variability and reversibility? It's reversible in bronchial asthma, where it's fixed or progressive airflow limitation in COPD. So we can conclude that persistent airflow limitation with poor bronchodilator response is a character of COPD, whereas in bronchial asthma, the reversible airway or the airflow obstruction with a significant bronchodilator response. We have another forms of post-bronchodilator spirometry known as early or non-classical COPD. The first one is early COPD. This term was introduced to describe individuals who have respiratory symptoms and or structural lung abnormalities, but don't yet show any airflow obstruction on standard spirometry tests, which means that their FEV1 over forced vital capacity equals or more than 0.7. Second one is PRISM. PRISM is preserved ratio impaired spirometry. It's a lung function pattern with abnormality characterized by reduced forced expiratory volume in 1 second, less than 80% predicted, but with preserved FEV1 over FVC ratio, which is equal or more than 0.7, indicating airflow limitation without fulfilling the criterion for obstructive restrictive lung disease. This category, which is PRISM, has gained attention. Why? Because it identifies high-risk individuals who don't yet meet the COPD criteria but have abnormal lung function. Also, it predicts disease progression, as many PRISM patients will develop airflow obstruction over time and develop fully diagnosed COPD. Third one, it's linked to systemic disease such as metabolic syndromes like obesity and cardiovascular disease. And we said before that COPD is no longer considered an isolated disease or simple disease, but it's a systemic one. Second tool in diagnosis is the radiography, chest X-ray to rule out any other lung conditions, computed tomography, which is more sensitive in detecting emphysema, airway wall thickening, air trapping, so it's more valuable in COPD assessment. Magnetic resonance image, MRI, which is it's less commonly used, but can assess lung perfusion and inflammation. So it's offering functional insights in research settings, not in diagnosis. Positron emission tomography, PET, and single photon emission computed tomography. Both of them are primarily used for research also, or in assessing inflammation, metabolic activity, and associated malignancy, rather than the routine COPD diagnosis. Also, chest ultrasound used to assess the pleural effusions, diaphragmatic movement, abnormalities in COPD patients. Ventilation perfusion scan usually helps to evaluate ventilation perfusion mismatch. So it's very important in detecting pulmonary embolism, which is very common comorbidity in COPD. Fluoroscopy. Sometimes it's used to assess the diaphragmatic paralysis dysfunction, also which can contribute to respiratory insufficiency in COPD. Bronchography, previously used to visualize bronchial abnormality, but now largely replaced by CT, computed tomography, and COPD evaluation. At last, skull radiography. It's rarely used in COPD, but sometimes it may be performed to assess sinus disease, which can exacerbate respiratory symptoms. The third diagnostic tool here is using biomarkers, but I'm expecting that maybe someone of you asks, maybe, why should we waste a lot of time and pay money in diagnosing COPD, which is quite easy in diagnosis? But here I can say that here is the difference in between a regular physician and good physician, where the good physician knows that the trick of his trade lies in blending his clinical experience in addition to innovative diagnostic tools such as biomarkers. Let's see what are the used biomarkers. First of them is blood eosinophil count, which is used to assess the responsiveness to inhaled corticosteroids, either good or moderate or poor. Fractional exhaled nitric oxide, it helps to assess airway inflammation. Serum alpha-1 antitrypsin and genotyping, with the deficiency of alpha-1 antitrypsin suggests emphysema, which is considered replacement therapy here. C-reactive protein, it's a marker of systemic inflammation, as all of us know, so it's used for risk stratification. And at last, genomic transcriptomic analysis. It identifies genetic predisposition, so helps classify endotypes for targeted therapies. Microbiological and infection workup in diagnosis of COPD is very important also. For example, sputum culture, it identifies chronic bacterial colonization to guide antibiotic therapy. PCR for respiratory viruses to differentiate the viral induced exacerbation, aiding in appropriate management. Definitely, TB screening in endemic areas helps to rule out coexisting TB, which can mimic or worsen COPD symptoms. Another test for systemic assessment, like ECG, it evaluates core pulmonale and heart failure in severe COPD. We can use the 6-minute walk test and cardiopulmonary exercise test to assess the functional capacity and exercise-induced hypoxemia. In addition to arterial blood gas analysis, to measure oxygenation, ventilation, and acid-base stats to guide management. Another test for comorbidity screening like osteoporosis screening, DEXA scan, it assesses increased fracture risk in COPD, which is common in COPD due to chronic inflammation and steroid use. Uh, Remember that we said before that COPD is no longer a simple or single disease, it's a systemic disease. And it was accompanied, or we said before, it's accompanied with depression and anxiety. So depression and anxiety screening is very important to identify the common mental health disorder affecting those patients and impacting their quality of life. Metabolic syndrome screening to evaluate cardiovascular risk in COPD through hemoglobin A1C, lipid profile, blood pressure assessment. No more dally-dally. It's the due time now to start discussing the management of chronic obstructive pulmonary disease, which consists of two big arms. The first one is pharmacological treatment with medications, and the second, more important, is non-pharmacological interventions. We are going to discuss one by one. Considering first the pharmacological treatment. Before starting the different pharmacological treatment for COPD, we have to make an agreement on some abbreviations. SABAs, look before the table, please. SABAs is a short-acting beta-2 agonist, whereas LABAs is a long-acting beta-2 agonist. SAMAs, short-acting muscarinic antagonist, whereas LAMAs is a long-acting muscarinic antagonist. ICS is inhaled corticosteroids, where PDE4 is a phosphodiesterase. So we can determine the treatment of each case separately, what we call personalized pharmacological treatment based on GOLD classification we've discussed before. So in the mild case, we can use SAMA or SABA. But if symptoms persist, we consider LAMA or LABA. Okay. If the case is more advanced, it's moderate case, GOLD 2 stage, we use LAMA or LABA, like the persistent symptoms in the mild case. But if symptoms still persist, we consider them both. We use LAMA plus LABA. In a more severe case, we use LAMA plus LABA, and we can add or not add ICS, inhaled corticosteroid. But inhaled corticosteroid, if eosinophils is more than 100 cells per microliter, and withdraw if pneumonia risk. So we use inhaled corticosteroids if eosinophil level is high. But if there is a pneumonia risk, we should or we don't use ICS. We use the PDE4, the phosphodiesterase inhibitors, in case of chronic bronchitis, and we can use macrolides for frequent exacerbations. Considering the case is more severe, which is very severe, we should use them all, LAMA plus LABA, plus or minus ICS, plus or minus phosphodiesterase inhibitors. Most of those patients are in need of oxygen therapy. Sometimes we have to use or we have to make lung volume reduction surgery. And there is a biological therapy, mepolizumab, for eosinophilic COPD. And here is the importance of making eosinophil count as a marker for COPD. Something very important to add here, using LAMA or LABA must always be used with ICS. LABA must always be used with inhaled corticosteroid only in asthma, because there is a risk of masking inflammation and increasing asthma-related mortality. In contrast, LABA is used as monotherapy in COPD, which is safe because the disease is already driven by airflow limitation rather than eosinophilic inflammation. So ICS use is selective due to the risk of pneumonia. And here is again the difference or the key difference in between using monotherapy of long-acting beta 2 antagonists only in COPD, but with inhaled corticosteroids in bronchial asthma. Another selective pharmacological treatment for COPD, we can use mucolytics for chronic sputum overproduction. Definitely, we can use antibiotics for frequent exacerbations, especially if the case is chronic bronchitis type. The interleukin 5 inhibitors, this group is called mepolizumab. This group usually target the eosinophilic inflammation, so it may benefit COPD patients, those with high eosinophilic count. It's a common line of treatment in bronchial asthma. Phosphodiesterase inhibitors, usually it's used to reduce inflammation by increasing the intracellular cyclic AMP, and it's used in severe COPD cases with chronic bronchitis and frequent exacerbations. Newer bronchodilators have a lot of trade names and depends or differs from country to country. The last one here is exposome-based therapy. Exposome-based therapy focuses on identifying and modifying the total lifetime environmental exposure. For example, air pollution, smoking, to personalize and optimize COPD prevention and management. So, exposome-based therapy, it's not a standard line of treatment or management. It depends according to the patient surrounding environment. Now, the non-pharmacologic interventions, two main approaches. The first one is rehabilitation, either pulmonary or occupational rehabilitation. Second point is, what about the gradual return to work? We are going to discuss one by one. First, the rehabilitation. And we mentioned before that rehabilitation is pulmonary or occupational. So, commonly, what are the goals of COPD rehabilitation? First, to improve exercise tolerance and muscle strength. Second, to reduce dyspnea and fatigue. To enhance quality of life and independence. To improve mental well-being and to reduce anxiety and depression. To facilitate return to work if applicable. And at last, to decrease exacerbations and hospitalizations. The question now is, who are the candidates eligible for COPD rehabilitation? Those patients with moderate to severe disease, GOLD, B, C, or D. Patients with significant dyspnea, MMRC is 2 or more, or CAT score more than 10, if you remember that classifications. Patients with reduced exercise capacity, those who are not able to make walk distance more than 350 meters in 6 minutes. Those with frequent exacerbations, 2 or more, or recent hospitalizations. Patients with muscle deconditioning or frailty or weakness due to inactivity. Post-hospitalization COPD patients, and early rehabilitation here is required to reduce the readmissions. Lastly, patients with anxiety or depression, and the smokers who continue to have symptoms despite cessation. Same question as before, but in a different way. Who might not benefit from COPD rehabilitation? Those with very mild COPD, GOLD A, without symptoms. Why should I do rehabilitation for them? Second, patients with severe morbidity limitation preventing participation. Some persons are totally unable to participate in such program of rehabilitation due to severe mobility limitations. Third, patients with severe cognitive impairment or unstable comorbidities, they are in more need for mental or for psychological management. Rehabilitation of COPD patient. Pulmonary rehabilitation or occupational pulmonary rehabilitation is done by exercise training, nutritional support, psychological support, and behavioral therapy. So, the pulmonary rehabilitation is done by exercise training, nutritional support, and psychological support and behavioral therapy. Second, occupational rehabilitation, it's a work environment modification. We will discuss every step, starting with pulmonary rehabilitation. The first step in pulmonary rehabilitation is exercise training, which is typically around 6 to 12 week structured program with at least twice weekly supervised sessions. It takes the form of either aerobic exercise and or endurance training, like for example walking, cycling, or even treadmill exercise, usually for at least 20 to 30 minutes per session, using intensity starting from 50 up to 80% of maximal capacity, which is measured usually by the 6-minute walk test or even cardiopulmonary exercise. The exercise test here for pulmonary rehabilitation usually improve the cardiopulmonary fitness, enhance oxygen utilization, and moreover, it helps reducing the breathlessness. Also increases the muscle oxidative capacity, delays exercise and induced fatigue, and enhances the ability to perform prolonged physical activity with less discomfort. In addition to aerobic and endurance training, we can use strength exercises and resistance exercise also for the same period, 6 to 12 week structured program for at least twice weekly. Usually using the upper and lower limb muscle training, which using resistance bands or light weights, as we see in the figures now, also twice a week to improve the skeletal muscle function. Strength and resistance training counteracts the muscle atrophy that occurs and happens in COPD patients. It improves the muscle strength and endurance and contribute to better balance, mobility, and independence. The third type of exercise training for pulmonary rehabilitation is breathing exercises. It's either pursed lip breathing or diaphragmatic breathing. In the pursed lip breathing involves inhaling through the nose and exhaling slowly through pursed lips, like if we are blowing out a candle. This is usually important to keep airways open longer, reduce air trapping, and improve ventilation and ease the shortness of breathing. Concerning the diaphragmatic breathing, it's very important. Inhale deeply through the nose, letting the abdomen rise, as we see in the figure or the picture or photo or whatever, and exhale slowly through pursed lips, letting the abdominal fall, as we see. The benefits here also improves the lung expansion and enhances oxygen exchange, promotes relaxation, and reduces the work of breathing, especially helpful in COPD with anxiety and depression-related dyspnea. The fourth and last exercise training in pulmonary rehabilitation is inspiratory muscle training. First one is resistive breathing training. It occurs through breathing through a device with adjustable resistance to increase the inspiratory muscle strength by making breathing harder. Second one is threshold loading. It uses devices with a set pressure threshold that must be overcome to inhale. Also, it ensures some sort of consistent level of resistance regardless of airflow rate. Third one is normocapnic hyperapnea. Patients must breathe at high lung volumes for extended periods to strengthen the endurance of respiratory muscles, and the last one is voluntary isocapnic hyperapnea, which involves breathing at increased ventilation levels while maintaining normal CO2 level to improve also both strength and endurance of inspiratory muscles. Okay, now we mentioned the nearly all the types of exercise training required for pulmonary rehabilitation. And now the second step required for pulmonary rehabilitation is nutritional support. Actually, this is quite clear that it depends on body mass index. Those who are underweight, usually they need support of high protein, high caloric diets to prevent muscle wasting, which is common among the COPD patients. While those with high body mass index usually may benefit from caloric restriction and weight management to reduce the burden of respiratory muscles by the high amount of fats due to overweight. So, under the title Pulmonary Rehabilitation, we discussed all the types of exercise required, nutritional support. The third point in pulmonary rehabilitation is psychological support and behavioral therapy. Anxiety and depression, as we said before, they are common in COPD patients due to chronic breathlessness and reduced physical activity. So it's highly required to carry on cognitive behavioral therapy in addition to strict programs of smoking cessation, especially for those who smoke with nicotine replacement or medication or whatever. Now we have to shift to occupational rehabilitation. We have discussed the pulmonary rehabilitation by three items: exercises, nutrition, and psychological support. While occupational rehabilitation is required. How? Uh, Work environment modification is very important in occupational rehabilitation of COPD patients. First, by reduction of respiratory irritants and air quality control in workplaces by elimination, substitution, isolation, or whatever. And we have to improve the ventilation, include workspaces and local exhaust ventilation by regular air monitoring and smoking restriction. Workplace ergonomics and task adaptations, we have to grant those patients an adjustable workstations with reduced physical exertion and automation as much as we can with assistive tools to reduce the evolving air pollutants. Also by flexible work arrangements, either modified work schedules or by keeping those patients away from the polluted workplaces by remote work options. Uh, Personal protective equipments and respiratory support and easy access to supplemental oxygen if needed. Workplace health wellness and programs by granting pulmonary rehabilitation integration, by employee health screenings, by emergency preparedness and workplace support. The last is we have to have emergency preparedness and workplace support. We have to have evacuation plans and peer support and accommodation policies. Now comes the moment of truth. When should we allow the patient with COPD after treatment and rehabilitation to get back to work? Actually, the answer is how we allow him to gradually return to work. The query, by another way of questioning, is how to assess the fitness of worker with COPD to return back to work. To answer such question, we have many factors depending on. First is the clinical key factors in fitness assessment to work, or the parameters or indicators of the patient himself. And the second part is the work or his job requirements. The first one is clinical key factor. how to assess the clinical key factors, or what are the parameters based on to define the clinical key factors. First of them is respiratory symptom evaluation. Does he have persistent dyspnea that may limit workability? Does he have chronic cough sputum production? History of exacerbations. If it's two or more, this is a high risk for work limitation. Second is pulmonary function tests. We have discussed it before, and definitely forced expiratory volume over forced vital capacity less than 0.7 confirms obstructive pattern, and these patients will be excluded from work. Third one is oxygenation status. Depending on the oxygen saturation, concentration, and if hypercapnia suspected, to assess the respiratory failure risk. 6-minute walk test also is a clinical key factor in fitness assessment. Distance less than 300 meters usually indicates reduced exercise tolerance, where oxygen saturation drop more than 40% suggests work limitation. The cardiopulmonary exercise testing, if needed, it measures the VO2 max and workload capacity. Also, chest X-ray and high resolution CT scan, if needed. It rules out other occupational lung diseases, for example, pneumoconiosis or fibrosis. It helps usually in differentiating the diagnosis. The second tool in determining the fitness to return back to work is job demand evaluation. It depends on the physical workload required from that patient. Sedentary job, no problem. Usually safe for mild to moderate COPD, while moderate physical jobs like walking, lifting, light or unheavy weights may be suitable to some patients with some adaptations. But heavy physical jobs like construction, firefighting, or anything like those work may be unsuitable for moderate to severe COPD. Also, in the job demand evaluation, what about the environmental hazards that worker work in? Definitely, exposure to dust, fumes, smoke, or chemicals may worsen COPD patients. If the temperature, extreme cold air or high humidity or high temperature or very low temperature, they can trigger the bronchospasm again in such patients. Definitely high altitude or confined space work may pose risk for hypoxemic patients with COPD. Work schedule considerations, shift work and prolonged hours may be problematic due to fatigue and medication timing. Now we have to take a decision. So what about the decision making? Either the worker is fully fit or fit with work modification or unfit for work at all. Fully fit for work, no restrictions, usually with the mild COPD, job without exposure to respiratory hazards, and adequate exercise tolerance, while fit with work modification among moderate COPD, but stable condition, but requires ventilation improvement, personal protective equipment use, light workload with a little adjustment, and usually such patients or workers need frequent breaks with reduced shift hours or job reassignment. What about those with or unfit for work, temporary or permanent restrictions? Definitely with severe COPD cases, those with severe hypoxemia requiring long-term oxygen therapy, they must be excluded. Also, those who are required to be involved in heavy exertions, dust fume exposure, or high altitude work. Now, how about or what about the gradual return to work strategy? Gradual return to work plan. There must be an initial part-time, for example, for the first days or first few days, 4-hour shifts only, with a slow increase in work hours and duration over 4 to 6 weeks. Then workplace adjustments with proper ventilation and air filtration, with use of PPE, respiratory personal protective equipment, especially respiratory protective equipment. And it's very important to carry on a regular follow-up of such patients with medical reassessment every 3 to 6 months, to do spirometry monitoring and workplace health surveillance. Long-term strategies for COPD persons it depends on home-based pulmonary rehabilitation with continuation of exercise training and breathing techniques, regular follow-up monitoring by periodic spirometry tests, and monitoring exacerbations and adherence to medications by patient and caregiver education, training on proper inhaler techniques, recognizing early signs of exacerbations, and seeking timely medical care. Surgical intervention is the last uh, intervention, non-pharmacological intervention, that's required if needed. Many interventions like lung volume reduction surgery, bronchoscopic lung volume reduction, polyectomy, or lung transplantation. And that brings us now to the end of our presentation. I hope I didn't left you under the weather rather than lefting you something useful, whether a new perspective, fresh idea, or even just a better understanding with no boring. I hope so. Anyhow, thank you all for listening me, and I stand up now for any discussion. Thank you again.